I'm an orthopedic surgeon. I specialize in foot and ankle surgery. I've been in practice for 20 years. I'm in a hospital for special surgery. I do a lot of ankle surgery, so I do ankle replacements, a lot of ankle arthroscopy. I'm involved with a couple of professional sports teams, so I see a lot of athletes. The most obvious way we've changed the way we practice, because if you're doing foot and ankle, you fuse a lot of joints. You fuse the tarsal metatarsal joint frequently, you fuse hind foot joint, sometimes you fuse the ankle joint. And the question always is the joint fused? Can we let the patient walk on it? In addition, we do a lot of fracture work. Is the fracture healed? And you're always just guessing. You're just hoping in 6 weeks it's healed, it's going to look fine. But the pedCAT takes all the variability out, all the guesswork out of it. We know that if it's healed, if it's fused more than 50%, we can let the patient walk on it. That's pretty much backed up by good data. So if we have a 50% fusion, we let the patient walk on it. And so that changes it. I let people walk earlier than before, and I keep them off it longer than before. So sometimes I think things are fused, and I'm not so sure the foot's a little swollen, I'll take a pedCAT. Or a lot of times, routinely, I'll take a pedCAT 6 weeks, because they come in for the question, can I walk now? I'm 6 weeks past my fusion, can I walk? That's sort of the first indication. The second indication is clearly ankle fractures. In the past 10 years, there's been a change from ignoring the posterior, probably the last 20 years, ignoring the posterior malleolus to really looking at the ankle fractures in three-dimensional pictures. So we CAT scan almost every ankle fracture, and we are surprised at the variability of the ankle fracture, and we're surprised at what we thought was the fracture pattern wasn't really the fracture pattern. These posterior pieces are often bigger than we thought they'd be on plain x-ray, and they often travel all the way around the medial side as well, which we never thought they did. You know, we thought it was an infrequent fracture. We see it routinely. And so what's really changed is most of my ankle fracture work, most of the time, I'd say more than half the time, I'm doing a posterior approach now, because I have a big posterior piece I have to go after. And for the first 15 or 18 years of my practice, I would do medial and lateral incisions. Now I'm doing a posterior lateral incision going to the back of the ankle. And that's really changed it. So in probably since in 2011, the past 6 weeks, we've done that 4 times. Every ankle fracture has gone posterior. And a lot of it's driven by the pedCAT. Lisfranc injuries, which is, if you have a Lisfranc injury, we usually see the patient. If it looks okay at x-ray, sometimes we get an MRI. If there's a little bit of a gap, then we'll bring the patient back in a couple weeks and let them weight bear on it and see if we can see something on plain x-ray. You can stand them right away and put both their feet in the pedCAT. And you can say it's gapped, it's not gapped, and you can get an answer. Same thing with a syndesmosis injury or high ankle sprain. Those are great indications for it. So we're using it all the time. I mean, it's hard for me now. I tell my colleagues it's hard for me now to take a plain x-ray, because I think I'm getting not enough information. But if you ask an orthopedic surgeon whether they have a CAT scan of an ankle fracture or a plain x-ray, you'd rather a CAT scan. The problem is everyone's fear of radiation, and that's what's really the easy sell. Now I'm trying to sell some patients, like, everyone's worried about radiation, so if I tell the patient, look at the same radiation basically as an x-ray, then they're happy with the radiation dose from plain x-ray and extremity x-ray. They're not happy with the x-ray dose from a CAT scan, so that is a big difference. And probably the final way, and we're really looking at this both from research and from our alignment, is our total ankles, we're looking at alignment. We're looking, to determine what position the foot is in. We do something called a Saltzman view, which is a double x-ray looking at the heel compared to the tibia. You don't really need that anymore. You can scroll right through the tibia to the talus to the calcaneus through different planes, and you can draw your alignment view very easily. So it really takes the guesswork out of it. For years, we had no reproducible, reliable measurement of hind foot alignment. The Saltzman view was clearly a great step. This is, head and shoulders above that. You're standing, we can rotate it, we can look at it from a bunch of different angles. Ankle fracture is a very common injury for the orthopedic surgeon. Most orthopedic surgeons in the country treat ankle fractures. And you're basing your treatment on an outdated system. You're basing it on Logie Hansen or AO system. You're basing it on, is it 25%, is the posterior malleolus 25%? That is all garbage. So you really see where to fix it. And you should try to fix every component of the ankle fracture. That's clearly been shown that the posterior malleolus is important. And so everyone who gets an ankle fracture gets the pedCAT. And it's a no-brainer on that. And then the question is a fusion. Is it fused? Can we let you walk on it? Can we let people walk earlier than before? And we let people walk later. So we give them, it's guesswork, takes the guesswork out of it. If you're more than 50% fused on the CAT scan, and the nice thing about the pedCAT is there's not a lot of artifact around the hardware. I've seen a great impact to make patient-driven plans. The ankle fracture stuff we've already talked about, where I've changed a lot, where I do way more posterior approaches to the ankle joint since I've been using this. Also, it's a little bit of humbling too. When you think you're putting screws in a certain position and you get these CAT scans post-op, I'm getting better, because what I think my plain X-ray is showing me, and where I think I put these screws on the X-ray, is not always the same thing. So the pedCAT, there's no faking it. So we're often in the office saying, okay, look at this screw on plain X-ray. Now, where do you think this is? And then we go back, now where do you think it is on the CAT scan? You look at the CAT scan, you're lower or higher. So we're really learning and to perfect our surgical techniques. If you're a foot and ankle surgeon, it's a little bit addictive. So you have to sort of hold yourself back in some ways, because you're going to want to know what's going on with every foot or ankle. You're going to want to know what the alignment, you know what the standing alignment is. You're going to want to be able to do a 360 view around there. It's really changed our practice. We're much better because of it. And the response to the patient, from the patients, is great. I mean, they're happy to see it in 3 dimension, and they feel like they're getting the best possible imaging study and the best possible care. And it's easy to explain to the patient. Here's your fracture, here's your skin, here's what's all swollen. We've taken away the skin, we've taken away everything. Show your fracture. It's very easy to see. Oh, the patients love it. It's first of all, when you tell patients you're in the office, now I have to send you for a CAT scan, patients are, where do I have to go? No one wants to go, because usually they're injured. Well, the ankle fractures. I mean, take a patient with an ankle fracture, now they're in my office. Now to get them to the hospital or an imaging facility, there's cars got to come, they're in a wheelchair, it's a lot of stuff. All right, roll them down the hall. We installed our pedCAT machine inside our X-ray machine. We didn't do anything else. We already have it was the smallest fit in our X-ray machine. So we just roll them down and sit next to our X-ray machine, and they take an X-ray to get the pedCAT right away. So the reaction's great. They also love to be able to see things in 3 dimensions. So we do this a lot. We give them their skin back on their foot, and then we sort of take it away and show the bones underneath and show, okay, now we have this, your ankle like this, and now your ankle's okay. Now we can rotate it around. We can look from the back. We can look from the front. We can decide what your alignment is. We can see your joints. And I mean, there's no better view than this. There's a way to look inside the ankle and your weight bearing. The weight bearing is the big issue. So in our office we have an extremity MRI scanner, we have plain X-ray, the PAC system, we have an ultrasound machine, we have fluoro, so we have pretty much everything you can use. I'd get rid of all of them except for the CAT scanner. If I had one thing, I'd use the CAT scanner because I can get all the information there. I order so many fewer MRIs than I do the CAT scanner. First of all, because it's easier to get pre-certification for our CAT scanner than is the MRI. The MRI, I always have to talk to someone. The CAT scanner, I've never had to talk to her to get pre-certification. I'm not sure if it's, in New York City, it's not an easy place to get these images. So I'm not sure why, but our office, it's much easier. If I say I want a CAT scan or MRI, if I get an MRI, I get a groan. If I get a CAT scan, they're pretty happy because we're pretty sure we can get it while the patient is here. And so, it's really made a big difference in terms of patient flow through, and I think it's going to be the standard of care.